And
there's the misconception that fibrates as a class are associated with adverse muscle reactions to statin. In fact, this is absolutely a finding with gemfibrozil, but with fenofibrate, a number of studies have looked at the combination of fenofibrate with statins and have shown that particularly when fenofibrate is used in individuals who don't have renal insufficiency, this is not an issue. Nevertheless, many guidelines discourage the use of fibrates with statins, and this is an area where really physician education is important to understand that there are certain cases in which fenofibrate is appropriate for use with statins. Niacin, similarly, should be used with caution, but can be used in conjunction with statins in appropriate individuals. Gemfibrozil probably should be avoided in almost all individuals receiving statins because it is associated with much higher likelihood of statin-induced muscle pain and statin-induced rhabdomyolysis, although that certainly occurs much, much less commonly than the muscle pain syndromes. Well, there are fortunately other alternatives that can be used in conjunction with statins when an individual is not able to tolerate the dose of statin that one would like to give, or when an individual receiving a statin does not achieve adequate lipid goals. Ezetimibe is a drug which blocks one of the cholesterol transporters in the gut, and which is a potent lower of LDL cholesterol, although not as potent, certainly, as the statins. And the recent IMPROVE-IT study showed that, interestingly, particularly in the diabetes subset, there was demonstrable benefit in reducing cardiovascular endpoints in individuals receiving statin plus ezetimibe. Other agents can be used, such as the bile acid sequestrants, bile acid binding resins. One of these is colesevelam, which has been widely studied. Interestingly, it is of modest but definite benefit in lowering blood sugar, and so may be particularly useful in individuals with diabetes. It has a complicated effect on lipids, may increase triglyceride levels somewhat, so it has to be used with caution in appropriate individuals, but certainly it works well either with statins or in individuals who are intolerant of statins in monotherapy. But both ezetimibe and the bile acid binding resins are only able to lower the LDL cholesterol by about 20%. And so recently, the culmination of a series of population-based genetic studies led to the realization that PCSK9, which is an enzyme involved in chaperoning the LDL receptor to and from the plasma membrane of the hepatocyte, may be very important in determining LDL receptor levels, and hence that PCSK9 antibodies may actually lower cholesterol. And a slew of large-scale clinical trials have demonstrated that these are extraordinarily potent agents in lowering LDL cholesterol, actually showing greater LDL lowering effect than maximal dose statins. And so we may be at the cusp of entering a new era of lipid therapy where the PCSK9 drugs, perhaps given in conjunction with statins, with which they work well, may be able to take individuals who have extremely high LDL cholesterol levels, those with familial hypercholesterolemia, for example, or individuals without FH but who have ASCVD, and bring them down to levels that were previously unachievable and might really reduce the likelihood of development of atherosclerotic complications.